Here is my presentation. It is entitled, My Eyes Have 350 Milliseconds of Latency. And here we go. So the overview of the patient. She's a 51-year-old female. The time that we saw her was February 7th, 2024 at 1 p.m., starting off hot right after lunch. It was a vestibular assessment appointment, and her primary concerns were dizziness along with visual disturbance. One set of symptoms kind of outweighed the other, but she had two distinct presentations, so we have a couple of different timelines to discuss here. So the first timeline began in 2018. She was experiencing intermittent episodic dizziness, and this occurred while she was out on a camping trip. She was out in the woods, picking berries, doing kayaking, all that stuff. And in the midst of all this white bread activity, she began to have dizziness, nausea, and emesis that lasted for hours. She subsequently went to the emergency room. She was given Zofran, antibiotics, and this all helped sort of reduce the symptoms and make her feel good enough to go back home again. Afterwards, she had a little bit of residual dizziness and nausea lasting roughly a week. And then ever since that time, for a 2-year span afterwards, she didn't have any recurrence of any similar symptoms. So all was good until it wasn't. Let's zoom forward to 2020. She had similar symptoms occur this time, but they had greatly reduced severity. Now, her symptoms would last for seconds to minutes, roughly once per month, and they had unique triggers. Instead of all of a sudden having this big confluence of symptoms, she now has to do these unique movements to trigger dizziness. So the movements were lying supine, rolling from prone to supine, and then when sitting upright and extending the arms and torso forward. Y'all remember standardized tests at gym class when you had to do like the push-up test and the sit-up test and do all that stuff? Remember the sit and reach portion of that? The one where all the dudes had terrible scores and the girls just dominated? Yeah, that is the exact movement that would trigger her dizziness, is that sit and reach. So, also, her visual field moves in a zigzag pattern, as if it were being shook on a 2D plane. So, like when you do the shake to reveals on your Instagram stories, it's just like that. Or for the older crowd, it's like erasing an Etch-a-Sketch. Now, she does not have any proprioceptive sensation of movement when this occurs. So, her visual field moves, but she knows she's staying still, and she feels like she's staying still. It's just her eyes are lying to her. And her symptoms can be largely prevented if she focuses in on one target, if she's able to just look at one thing and one thing only. Even when she does these triggering movements, she will avoid having dizziness symptoms. So routinely, she takes an antiemetic roughly 3 to 4 times per week to make sure that her symptoms are not exacerbated. She takes Flonase to prevent oral fullness, but she otherwise does not have any ear concerns, no hearing loss, no tinnitus, no nothing like that. When I learned that she was having difficulty going from prone to supine, I asked if she's tried the inverse, supine to prone. She said she has not tried it yet. But also, her symptoms are not triggered by looking upwards, they're not triggered by loud noises, not triggered by physical strain. She also denied any autonomic symptoms, so no heart rate increases, no cold sweats, no body temperature dysregulation, no nothing like that. And then she also denied vertigo in all directions, no turning, no rocking, no tilting, no sliding, no nothing like that. I'm going to present the vestibular data, not necessarily in chronological order, but in terms of what makes most logical sense for the presentation's sake. So I will start with VEMPs. So we have her VEMP data right over here. As you can see, we got nice clean P1 to N1 peaks. This is showing a nice positive response on both sides. The amplitudes are within normal limits, and the amplitudes are symmetrical with one another. Going to VHIT next. And again, just like VEMPs, we got a nice, clean, normal result here. Now we're going to go to the rotary chair. So we'll start with the smooth pursuit. Horizontal. Her eyes are tracking that dot moving from side to side very, very nicely. Now, saccades. This is the first place where we see something interesting. So let me explain the tracing real quick. You see the solid black line. That shows where the dot is in space. Now, what you want to see is these little pink squares meeting that solid black line. But what we see here is some of the pink squares sort of go part of the way, but then you have this green portion. This green portion indicates where her saccade has stopped, and she has to sort of compensate for her saccade not going all the way to where the dot has moved to. All right, so then we decided to make the chair rock side to side. So we have her SHA data right here. And I'm going to get the easy ones out the way. There was no signs of asymmetry, and the spectral purity was all within normal limits. As you could see, in a couple of the medium frequency trials, she had these phase lags here. And then also, outside of the 0.02 hertz, she had hypometria on all of her SHA trials. So 0.04 hertz, 0.08 hertz, 0.16 hertz, all of them did not show as much eye movement as we would expect. Now the 0.64, that's kind of on the borderline here. It's almost within normal limits. You could talk me into it if you pay me enough money, but we're not seeing anything that we would normally see. Let me give you a little insight into that. So here is the 0.64 hertz SHA. You don't need to pay too close attention to it. Just look at how her eyes move and how much they move in general. All right, so I'm going to recontextualize this by letting you see the SHA of a patient with normal. All right, so this one we did the visual fixation test. We put the little red dot on the wall so that way when the SHA did its thing, we were going to have her look at the dot to make sure that she could fixate the nystagmus away. We were in good shape there. That result was totally normal. Then we did the equal and opposite test. We illuminated the disco ball that's above the rotary chair, had the chair do its thing, and had her watch all the lights go by. So the Studio 54 test, again, 110% gains right there. That's within normal limits. All good. Now, unfortunately, that was the end of the all good. We have subjective visual vertical right here. The subjective visual vertical is a test we use to let patients tell us what they think vertical looks like, given just their vestibular information. Vertical was a little skewed to the right, but the thing is, vertical was this really wide moving target for this patient. There's a very big variance number right here. And then also the mean, while it's still technically within normal limits, it's pretty close to being outside of it. So with this big wide variance and that rightward skew deviation, that led us to indicate that this was an abnormal result. Also, we took her through the velocity step test. So we had the chair do some spinning, and then we stopped the chair in its tracks, and then we watched for eye movements. So this is with the rightward rotation, and you will see the chair stop right here. And then you see this nystagmus. So this nystagmus persisted for a good little bit of time. It wasn't a crazy amount of time, but this was still a normal result. Now we flip it the other direction. And then we're going to see how long it takes for this nystagmus to fatigue. Chair stopped. And look at that right there. Like there's a little bit of nystagmus still left over, but it's not taking nearly as long to fatigue as the right side is. So here are some questions to consider. What do you think is the patient's primary pathology? Also, do you think that the two instances of dizziness are connected in any way? What referrals would be appropriate? And then lastly, what other information would you want to see? Would you want to see calorics? Would you want to see enog? Would you want to see a cochlear microphonic? Would you want to see PT data? I challenge you all to take your best shot. I want to let you in on something. There is a clue somewhere in the presentation as to what the pathology was.